The moderators of the day are Dr. Basanth Rayani and Dr. Vibhavari Naik. Dr. Basanth is the head of the department and is an accomplished anesthesiologist and is really keen in the Onco work going on. And Vibhavari, the senior most deputy of Basanth, working in the same hospital, and she's an excellent academician of the day and a good speaker. And these two will be controlling the session of the day. Before that, I would like to say that the Yearbook of Anesthesiology 2023 was released last week at Chandigarh. The book is available from JP's as well as through Neon. You may be able to collect a copy, and the book is reviewed as one of the best yearbooks which we are able to publish for so far. And friends, our membership is increasing, and I may like to give you a tip that membership fee may be increased because the present president is very anxious of increasing the numbers to ICA, and probably the membership fee also will be increased, and the style of membership also will be changed over from lifetime membership to annual membership to make more people visible always through our interactive programs. And today, if you want to become a member, it is very easy. You fill up the application and give it as the direction being shown in the application, and you will be given the ICA numbers. And probably this is one of the organizations where you're going to get a cheap membership, which I am afraid may change over. So today's program on the Onco anesthesia and the advancing areas in Onco anesthesia is going to be discussed, and I request Dr. Basanth and Dr. Vibhavari to lead the show. Basanth, Vibhavari, please go ahead.
Good evening, everyone. At the outset, I would like to thank ICA for this opportunity. I would like to thank Dr. Radhakrishnan, Dr. Jayashree Sood, and all the office bearers of the ICA for the opportunity. Yes, as Dr. Radhakrishnan sir had mentioned, we had the part 1 of the Onco anesthesia webinar earlier, and we wanted to look at something which changes in the onco surgery have had anesthetic implications, and so we have anesthesia for HIPEC surgeries today and anesthesia for transoral robotic surgeries. And the third one is the anesthesia for cancer survivors. This will be a very important topic for the anesthesiologists who don't see much of onco anesthesia, and also for the postgraduates. So without wasting much time, we'll move on to our first topic, which is anesthesia for HIPEC surgeries by none other than Dr. Solanki. He's very popular in the onco anesthesia groups. He's a professor in the Tata Memorial Hospital, Mumbai, editor of the perioperative critical care book. He has earned lots of awards. He's the assistant editor of Indian Journal of Anesthesia earlier. And he's actually the secretary of SOPSIC on the Society of Onco Anesthesia and Perioperative Care, and EC member of IDA. Yeah, areas of interest, HIPEC and hepatobiliary surgery are some of his areas of interest. And over to you, Sohan, for your presentation. Thank you.
Yeah, thank you very much, and good evening, everybody.
We can hear you, Sohan.
Yeah, actually, I'm just going. Okay. Yeah. So my topic is this CRS HIPEC in its anesthesia and the perioperative management. It's not shifting. Okay, so these diseases are actually, they are either from the primary peritoneal disease or some meds from any GI or gynec cancer. And traditionally, these diseases were considered to be having a very poor prognosis, and they were considered as an incurable disease, and patients were actually were sent to the palliative care physician or home for just care earlier. But in like late 90s, Dr. Paul Sokubeker from USA showed that actually this surgical removal of the visible tumor combined with the heated regional chemotherapy can actually improve the quality of life and survival in this type of patients. So why we do this CRS or this call it this cytoreductive surgery? Because we can remove the peritoneum completely from the body, and normally there is no distant metastasis, and all the macroscopic tumor can be resected from the body. So you see this type of jelly structure in the abdomen, full of abdomen. These patients are mostly from the having a big peritoneal diseases. Why we do HIPEC? Because after surgery, we can directly give the heated chemotherapy into the abdomen in the operating room only, and they have a better penetration because the surface is very raw, and heat and chemotherapy, they can have a combined effect of the cancer to kill the cancer cells. And the chemotherapy is used as mostly either carboplatin, cisplatin, mitomycin C, or oxaliplatin, because they have a good heat synergy and they have a good penetration into the tissue. And the most important thing is they are non-cell cycle specific, means they can kill the cell in any cell cycle. Okay, and also they have a good intraperitoneal to intravenous ratio. Some other drugs like paclitaxel and this 5-FU, they can also be given because they have very good intraperitoneal to intravenous ratio. So they will be mainly remaining into the peritoneum, but they don't have any heat synergy, and they are also cell cycle specific. So if the cancer cell is in particular phase, then they can only kill. So these drugs are less popular, but most popular drugs are these four. So to do this HIPEC and CRS, so and there is always a learning curve for surgeon as well as for the anesthetists. We need a lot of expertise, lot of equipment, and long duty hours and everything. So there is a learning hour for everybody. One important thing is that we should select our patients very carefully. So we should select, I told you earlier, so we should select only the primary peritoneal cancer or meds from the GI or gynec cancer. There should not be any extra abdominal disease. There maybe sometime we can choose the patient we have a minimal disease into the pleura, and patient should have a good performance and physical status. So when your surgery is planned, so we have to prepare the patient. We have to undergo the pre-habilitation for the patients. So we have to assess the patient, what is the risk, how the patient is fit, what is the physical status, what is the nutritional status, how the patient is emotionally, what is the emotional vector of the patient. All we have to see. And if you see that if they just this nutrition is bad, then this patient have a high post-operative complications and less survival. Also, if the patient is having ASA 3 or 4, obviously they will be having a bad prognosis. And also if the patient is having an ECOG more than 1, then they also have a bad prognosis and the most post-operative complications. So in 2019, we came out with this international guideline, and we published in our Indian Journal of Anesthesia with the guideline from the SOPSI. Me, Dr. Basanth, they all in and Dr. Shagun, we are all in the guideline authorship. So this HIPEC is actually divided into mainly 3 parts. The first part is the CRS part or the cytoreductive part, then comes the HIPEC part and the reconstruction part. These are the 3 intra-op part, and then the post-op part is different. So in the CRS part, all the disease which is we can see from the eye, they are all removed from the abdomen. And in the HIPEC phase, so they are arbitrarily divided into H1, H2, and H3 phase. And there is one H0 part which actually has some half an hour to 1 hour prior to the HIPEC phase. So where we prepare the patients for the HIPEC. So HIPEC, where we give the heated chemotherapy intraabdominally into the operating room. And after this HIPEC phase, the start the reconstruction phase where the surgeon can do the anastomosis and hemostasis and the closure and the shifting of the patient to the ICU or the recovery room. About the what is the disease load? So disease load is actually calculated by the scoring like made by the Dr. Shagun Bhatia Shah, which is called the PCI, the peritoneal cancer index. So it is like divided the abdomen into the 9 quadrants from 0 to 8, and divided the tumor from size like L, like lesion size 0 is like when there is no tumor in the particular area, and 1, 2, 3 based on the if the tumor size is less than 0.5 or 0.5 to 5, and if the more than 5, then it's called score given is more than 3. So the maximum score is 39 and the minimum score can be 0. So how good is the surgery? So it is like again is calculated by a scoring called the CC score, or called the completion of the cytotoxin score. So where like CC 0 is there is no peritoneal like seeding or any disease left after the surgery into the body, and CC 1, 2, and 3 it's like when the tumor nodule of 2.5 and above they are remaining in the body, and when they just CC 2 or CC3 it is called the incomplete cytotoxin, and at that time if you do the HIPEC after this, there will no clear benefit of giving HIPEC if you are not done the CC 1 or 0. So for these patients, when we like assess and when we do like rehabilitation, so we have to see this patient at least, I will consider that say at least 1 week. If we have more time before surgery, you can up to 4 weeks prior, you can see the patients so that you can optimize this patient for a better outcome. We always do a 2D echo because these patients may sometimes mostly maybe old, or maybe because we are giving a lot of fluid intraoperatively, so we should know heart functions, and like 1 to 4 weeks prior to which we see the patient. We also recommend, because all these patients should undergo this nutritional optimization. So we start oral nutrition in the patient. If the patient cannot take oral, then we can give the enteral nutrition by the rice tube or something. But we have to give a good rehabilitation to improve the outcome. For the physiotherapy and some physical exercise, so we have to like sorry, I'm just. So we have to give some kind of muscle training or aerobics or some walking or some exercise the patient should do before the surgery. Intraoperatively part, we do as just like any big major surgery. So we standard monitoring, like all we use the standard ASM monitoring. Invasive BP we use in all the patients. Core body temperature is must, because patients go a lot of thermal fluctuation intraoperatively. Cardiac output monitoring, I personally use in all the patients which are not very low volume disease, but in a moderate or high volume disease, always use this cardiac output monitoring. And central line we always put, because many times we need to give some vasopressors, but we can also measure the CVP. About the fluid therapies and the monitoring. So like the basic and advanced monitoring, I told you already, we can give. It depends on the how bad is the disease. If the very low volume disease, so you may not require like some adding cardiac monitoring, but in the high volume disease, you must use. We can use like these tests based on the any like pre-operative. If the patient having a bad heart or bad lungs, then we can also use. And if there's a very high expected fluid and blood loss, then we should also use the advanced monitoring in these patients. So gold directed fluid therapy, when we use with this cardiac monitoring, we can keep a goal of either SPV or PPV. When we don't have the this cardiac monitoring, that we can use the only PPV, which is based on the only your arterial line, or the stroke volume and delta stroke volume. And if they don't have anything, then you can use the lactates if we are using the EBG. And we can give this balanced salt solution, colloids and blood and all these things based on. So normally we keep the transfusion trigger at around 8, more than 8, or in some patients we keep around 9 or even 10 sometimes. And we can give the FFP, or we should give FFP based on the INR, because many times we will see the intraoperatively we send the labs and your INR may go up. So this is the HIPEC suit. This is the my operating room pictures I taken at different time point. So this is the cardiac monitoring I use, this is outline I use, a central line also used, and all this monitoring. And this is the HIPEC machine I will tell you later. If you have a new monitoring system, which is the HPI, the hypertension prediction index, I used in 4 or 5 patients, and I published this data. So this HPI has better two parameter better, like one is the EDINE and one is the DPDD. They are actually the like some contractility and the dynamic arterial elastance, and they can give based on that you can give either fluids or either like what should be given. So you can choose this very better. And the HPI, so HPI is the you will if the SPI is this 80, 85, 90, 100, they can say my patient may have hypertension after 5 minutes or 10 minutes, something like that. So you can actually predict the hypertension beforehand. The goal at different phase of surgeries, that CRS phase we manage just like any major abdominal surgery. HIPEC phase we ensure a little bit of higher urine output as compared to other surgeries. So around 2 ml per kg, I ensure the urine output. So I give fluid according to that. And so for to keep the temperature like in the control, we have to give large amount of the cold fluid. So in this way, the cardiac output, cardiac index, and stroke volume rise exponentially, and it leads to the hyperdynamic circulation, which settles over the next 24 to 48 hours. And because of the hyperthermia and all these things, the patient may have a high lactate, hyperglycemia, and hypokalemia because of the forced diuresis happening during the HIPEC phase. And then comes the reconstruction phase, where actually hyperdynamic circulation continues. I already told you this. So in the HIPEC phase, so I told you in the H0 phase that we start the H0 phase when we start preparing the patient for HIPEC. So we're starting at least half an hour to 1 hour prior, where we start the passive hypothermia. We do not actively cool the patient, but we just stop this warming devices and the fluid warmers, so that the patient can have a good temperature of around 35 or maybe at least 34.5 something. During HIPEC phase, we give the chemotherapy based on what disease type is then, and we need a carrier solution around 1.5 to sometimes 3 liter or 2 liter, and the most commonly used is the peritoneal dialysis solution. So temperature of the intraperitoneal chemotherapy given is around 41 to 43 degrees centigrade, and so that for that we use the good amount of IV fluids to keep the temperature low. And we give the temperature this cold fluid given at the 6 degrees centigrade. So we do not keep in the freezer section. We keep in the lower section of the freezer to avoid any ice formation of the fluid. And we have to keep the temperature around 37.5 to 38. But if your temperature goes beyond 39, you can tolerate up to 39. But if you go beyond 39, you can actually ask your perfusionist to decrease the temperature of the perfusate. This is the circuit of the HIPEC. This is the video screen where you see the temperature, and this is the this roller pump where you see the at once and there will be heated chemotherapy going in and then from coming out. Various circuit just like we use the cardiopulmonary bypass. This is the HIPEC machine. So you see the temperature of the 4 temperature, and we are going to abdomen, and the one is coming and one is going. So this is the HIPEC machine. This is mainly for the Belmont pump. This is made by the Belmont. Here output I already tell you, in the CRS phase, just like in any major abdominal surgery, 0.5 ml is enough. During HIPEC phase, 2 ml is supposed to be good. But if we are using cisplatin chemotherapy, we can actually even maintain high urine output, maybe around 3 or 4 ml, because there are a lot of reports of having AKI after cisplatin chemotherapy HIPEC. So diuretics mostly not required, but if your urine output is very bad, then you can use either Lasix or mannitol. And in the reconstruction phase or post-op phase, you are again the same, just like any major abdominal surgery, 0.5 to 1 ml per kg per hour urine output is good. I told you about the AKI after HIPEC. So there are a lot of reports of AKI, and we are actually in process of doing a systematic review on AKI after HIPEC, and hopefully will come out soon. whichever. In the post-op part, so we can continue all the monitoring which we are using in the OT, can continue in the post-op period. About the extubation in the OT or post-op elective ventilation, so that depend on if the patient is undergoing a diaphragmatic stripping, which is mostly in the case of the cerebral peritoneal, they mostly do the bilateral diaphragmatic stripping. In that case, it is good to ventilate the patient and don't extubate in the operating room. And also, if your patient is having a preoperative bad lungs or severe cardiac disease, or any patient is not stable hemodynamically, or your high vessel pressure support, then actually we don't extubate in the OT. So a low volume disease without diaphragmatic stripping can be extubated into the operating room. And even in the ICU, the recovery room, when you extubate next morning, it is good to give an IV or a high flow nasal cannula after extubation to prevent any atelectasis in the post-op period. We have to give a good analgesia, so that thoracic epidural analgesia we always give in the pre-operative period, and then it continues till the 3, 4, 5 days. So a good analgesia is required. Maintain urine output, aseptic precautions, all these are necessary in the post-op period. So one more thing, if the patient is having a diaphragmatic stripping and undergone a total peritonectomy, then these patients always require a very high fluid in the post-op period. We have seen 2-3 patients which actually were collapsed in the post-op periods because the fluids were not given enough, and so we came up with the protocol that if the patient had undergone total peritonectomy, very high volume disease, then we have to go and give very high volume of the fluid in the post-op period for at least for first 24 hours. We have to see all the labs and electrolytes and the PT-INA in the post-op period, and we do blood gas at lactates and all these things, and we have to start the feeding as early as possible. Mostly enteral. If not tolerated, then we can go for the parenteral nutrition. This is so complications. Mostly the intra complications are mostly either major blood loss and hemodynamic instability. That's the only 2 complications happening most of the time. But post-operative, there are many complications, either surgical or non-surgical. So surgical complications are mostly either leak or abscess or some infections. But non-surgical, you can have pneumonia, coagulopathy, sepsis, DVT, embolism, AKI are very common. In 3 patients, I've seen the hyperammonemia, and the cause is still not known because the patient are not having any liver disease or any of these things. And the rebound hypothermia, because if we are keeping the temperature high till HIPEC phase at temperature around 30 or 30.5, and then we are all the warming devices stop, and after HIPEC phase we forget to start again, and then patient can go into the rebound hypothermia, and that can lead to a major problem. Just 5 days back, we came out with this systematic review of the post-op complication and the management of CRS HIPEC in the post-op period. So we included around 14 articles, and we saw that there were complication rates of around 12 to 60% morbidity, and the mortality is around 1 to 6% average mortality in the all the studies we have seen in the post-op period. Other advantages, that some of the advantages, only some of the recent advances is that if the patient is not amenable to surgery, which is very high volume disease, and they cannot go for surgery, then on this patient they are actually giving the pressurized the chemotherapy in the aerosolized form, that is called the PIPEC. So you can give 2, 3, 4, 5, 6 sessions of the PIPEC, and then sometimes the patients can respond well, and it can be operable after that. So this PIPEC is also a good form of mostly palliative, but sometimes it can be curative also. And other this thing is the high-tech with this is called the thoraco-abdominal chemotherapy, where when especially in the pseudocarcinoma peritoneal case, when your disease is also having into the pleura and all these things. So while during the surgery, the diaphragm is open, and then the disease from the pleura is removed, and while keeping the diaphragm open, the chemotherapy is given into the abdomen. It will also go into the pleura. So it is called the hyperthermic thoraco-abdominal chemotherapy. We have done around 2 cases here, but we are mostly not seeing the patients which are having the this pleural mets, but we are seeing only 2-3 patients. Other advances that we can give the bidirectional chemotherapy, which is called the HIPEC plus, or the systemic and the intraperitoneal chemotherapy both, or sometimes we can give the neoadjuvant laparoscopic HIPEC also. And also sometimes the surgeons don't want to give the chemotherapy into the same time. They give the early post-operative chemotherapy. They just keep the peritoneal ports, and they give the chemotherapy next day or maybe after 2 days. And sometimes the disease is only into the thorax. So in that time, they do the hyperthermic thoracic chemotherapy. So it is mainly for the thymomas or some extrapleural pneumonectomy. After that, so they can give that. But this HIPEC is very much morbid procedure, and the outcomes are not very great. So in our hospital, we started in 2000, HIPEC we started 2015. In 2016 we started the study, and we have done around 204 cases I analyzed till now. And the average blood loss in the CRS phase by around 2.5 liter and 493 minutes by the time average duration. We was also good. And we can see this, the lactates during the HIPEC phase always rise because of the hyperthermia effect and not because of the high hypoperfusion. And the SCVO2 factor is a little bit low and during the HIPEC as compared to the CRS phase. And you can see that we have to able to maintain the temperature pretty well from the CRS to the post-op part, and the cardiac output is also slightly increased from the HIPEC phase, and then lead to the hyperdynamic circulation. And so these are all pretty well parameters. So my take-home message is that the peritoneal cancer is not a death sentence, and it leads to a high-risk surgery. You may be having a very high risk perioperative period. So we have to do a proper preoperative evaluation and optimization of the patient. We have to be ready to manage the hemorrhagic shock, and the goal-directed fluid therapy and the adequate hemodynamic and temperature monitoring is must for every patient, and adequate urine output, especially during the HIPEC phase, should be maintained, and especially if you are giving a cisplatin chemotherapy, and a proper post-operative ICU care is required, and we have to feed the patient as early as possible. Thank you very much.
Thank you, Dr. Sohan, for elaborately covering the topic anesthesia for HIPEC surgeries, and also briefly touching on PIPAC and HITAC. So more and more centers across India have been performing these type of surgeries. I think in the last 5 years, the numbers have really improved. And I'm sure that a lot of anesthesiologists who are in our audience are going to get benefited from your talk and may have some questions. So gentle reminder for the audience to please put in your questions in the question box on the ClearNet platform. We now move on to our next topic, which is yet another type of specialized oncosurgery, and that is transoral robotic surgery. And for this, we have our speaker, Dr. Shagun Bhatia Shah, who is a senior consultant at Dr. Rajiv Gandhi Institute of Cancer and Research Center, New Delhi. And the transoral robotic surgery is relatively less performed in centers across India. But since we have the Indian version of the robo out in the market, it is more likely that there could be more and more centers doing these type of surgeries. So let me introduce to you Dr. Shagun Bhatia Shah. And her interest is, of course, in anesthesia for robotic surgery. And apart from that, she's also interested in difficult airway management, cardiac output monitoring, thoracic onco anesthesia. And she has authored 85 publications in national and international journals and 8 book chapters. She's also received many research awards, and she's been an associate editor and section editor for some of the popular anesthesia journals. Over to you, Dr. Shagun.
My dear fellow anesthesiologists, a very good evening to all of you. I'm Dr. Shagun from Rajiv Gandhi Cancer Institute and Research Center, Delhi. And the topic of my presentation today is transoral robotic surgery and anesthetic considerations. Okay, so today we'll discuss the surgical robot, why robotic surgery is important with a focus on transoral robotic surgery. We'll discuss its flip side. We'll discuss the non-technical skills involved, the theater setup, the pre, intra, and post-operative management of TORS cases, and also the future directions. Right, this is your patient's perception of the surgical robot. So in the PAC, you have to educate your patient. You have to tell him that, yes, although yours is a robotic surgery, the robot is still a slave and the surgeon is still the master or the boss. They have a master-slave relationship. Now for the timeline, the first robotic surgery at Rajiv Gandhi was performed in February 2011. It was a robot-assisted lap prostatectomy. Then we did our first transoral robotic surgery in 2013. And till date, we've done more than 5,000 robotic surgeries here so far. Right. So this is the Da Vinci surgical system, which has, it enjoys a monopoly as a surgical robot. It has three parts. First is the console, which has the stereoscopic eyepiece, two actuators to control the robotic arms, and foot pedals to control the camera and the diathermy. Hand motions of the surgeon are transmitted to the robotic arms that hold the surgical instruments. The second component is the 2D vision tower, which records and displays the surgical site for rest of the OT team, and it also houses the insufflator. The third is the surgical or the patient cart, which we colloquially call the robot. The central arm holds the video telescope. The right and the left arms perform the manipulations, and the fourth arm functions as a stationary retractor. So why is robotic surgery so popular? That's because it gives you 3D vision, digital camera zoom, endo-wrist technology with increased dexterity, 7 degrees of freedom, no fulcrum effect, better ergonomics, unlike laparoscopic surgery. It gives you motion scaling, elimination of physiological hand tremors, and also one can visualize the nerves and perform nerve sparing surgery if you inject dyes like indigo cyanine green. So there is reduced operative trauma, smaller incisions, minimal blood loss, reduced blood transfusion, reduced risk of infections, less patient discomfort, and faster recovery. And also telementoring and telesurgery is possible, right? So why should we go in specifically for TORS? On the left-hand side, you see the image of an open commando surgery for base of tongue being done. And then you see that the open surgery suture line is extensive, unending. That's because the surgeons have to work. The line of sight working corridors are there, for them to work. But then when you're performing TORS using the Da Vinci surgical robot, there is better cosmesis. There is no external incision, so no scar. And more so, no tracheostomy in most of the cases. Right. So your patient is really, really happy with the cosmetic result. Moreover, there's reduced blood loss, there's reduced blood transfusion with its associated risks. There's a shorter duration of primary tumor resection. There is reduced post-operative pain with a reduced requirement of opioids. There's an opioid pandemic running. So there's if less of opioids are used, there is less of nausea, vomiting, constipation, less of opioid-associated cancer recurrence, and so on and so forth. There's a reduced risk of post-operative wound infections, less nasogastric and PEG feeding is required, and there's an early return to normal speech and safe swallowing. There's a reduced risk of venal thromboembolism and a reduced requirement for neoadjuvant chemotherapy as well as radiotherapy. So in a nutshell, There is a reduced length of stay for the patient with an improved quality of life, which means the world to him. But there's a flip side to TORS as well. The initial setup is costly, maintenance requires an added cost, plus the disposables too are costly. The robot is bulky in size and it's difficult to access the patient. There's separation of the surgeon from the operative field. There's no tactile feedback. There's monopoly of a single market leader, the Da Vinci, and then there's a chance of breakdown with any other machine. And then there's a risk of potential conversion to open surgery. Moreover, the OT table has to be rotated 180 degrees away from the anesthesiologist field. Crush injuries from robotic arms may occur. Positioning related nerve injuries may occur too. And then there's a steep learning curve involved. Ethics of training also have to be looked into. Right. So there's no space at the head end of the table. The anesthetist with his workstation is pushed to the foot end because the chassis of the robot is positioned over the patient's head. There's a difficult airway access during emergency conditions, be it an airway emergency, be it a cardiac emergency arrest or whatever. And then there's a time delay to undock in case of a complication. And moreover, any intraoperative movement of the patient can have disastrous consequences. But there's a brighter picture. That's medical tourism. Did you know that the cost of a single robotic surgery in India is just $2,000 compared to the same surgery in US, UK, Singapore? It would cost 100 times more out there, So cost of robotic surgery in India, the average cost is around 4,55,000 rupees, which is very pocket friendly. What are the indications for TORS? You have benign lesions of the oral cavity, larynx, pharynx, tongue base. You can also go in for obstructive sleep apnea surgery. Then the most common malignant lesions for which TORS is used is cancer of the base of tongue and carcinoma tonsil. There are several contraindications as well. Trismus, limited mouth opening, macroglossia, all these leave you with very little space for the robotic instruments in the oral cavity. Then mandibular or maxillary invasion, carotid or bone involvement are other contraindications. The pre-anesthetic checkup is pretty much routine, but then you have to lay a greater stress on airway assessment. History of previous surgery and radiotherapy should be assessed. Radiological imaging should be displayed, like you can see on the right-hand side. You can see an MRI, and you can also see a point-of-care ultrasound of the nasal cavity being done. And both of these can tell you which nostril is more patent and for your nasotracheal intubation, so that you avoid cuff rupture and you can avoid a serious bleed due to a spur or something present in the nasal cavity. Previous DS-copy, nasoendoscopy, pan-endoscopy reports all should be looked into. And most importantly, there should be communication between the anesthesiologist and the surgeon. Moreover, dental assessment is important. Crowns, caps, loose teeth, all should be noted. Investigations. Besides the baseline ones, additional investigations based on risk factors and symptoms at presentation. For instance, thyroid profile is to be done in post-COVID patients and post-radiotherapy patients. An echocardiogram has to be done in addition in post-chemotherapy patients or CAD patients. All right, monitoring. Besides the standard ASA monitoring, we insert an arterial line to measure the cardiac output for stroke volume variation measurement for arterial blood gas analysis. And we also insert a central venous pressure line to know the hemodynamic status and to inject drugs like vasopressors and potassium chloride. PNS, now that's very, very important because like I already said, any movement of the robotic arms with the patient, with the robot dock, any movement of the patient can result in serious damage, serious tissue laceration, nerves, vessels, so many things can get injured. Monitoring the depth of anesthesia using the bispectral index too is important. Now for the anesthetic agents. Mostly TORS is done under balanced anesthesia, but in case they're using laser for TORS, then you should ensure that the FiO2 is around 0.3 because you don't want to get into a risk of airway fires. TIVA with propofol is a good option because propofol reduces post-operative nausea, vomiting, reduces stress-induced vasoconstriction. It's immunoprotective, anti-inflammatory, and antioxidative. Now, this is the OT configuration for TARS. Like you've seen, the anesthetist with his workstation has been pushed to the foot end of the table, the head end being occupied by the assistant surgeon, the scrub nurse, and the patient side cart or the robot. Right. So the OT table has to be rotated 180 degrees because the elongated pedestal at the head end becomes the foot end, and now it does not obstruct the patient cart. Otherwise, when you move in the robot, then the pedestal comes into the picture. Then extension lines have to be applied to intravenous catheters to make them more accessible. Monitoring devices like the pulse oximeter probe and the peripheral nerve stimulator electrodes have to be placed on the lower limb instead of the upper extremities. Then extra long breathing circuits are required, and these are improvised by connecting two circuits end to end to cover the extra distance between your endotracheal tube and the workstation. To reduce the risk of disconnect or kinking of the tubing, you remove the angle piece when using a nasotracheal tube. The breathing circuit is placed in an upward direction over the head end of the OT table, running along the side contralateral to the robot or the robotic arms. So you see, my friend, the airway is shared, but the head end is definitely not shared. This is what the surgeons put into the oral cavity. They'll put the hook tip, spatula tip, needle drivers, forceps, scissors, lasers, dissectors, so on and so forth. And what do we put into the mouth? We put the laryngoscope only to remove it after a few seconds. And we put a small-sized flexometallic cuffed endotracheal tube. We do not put any Ryle's tube, and we do not put any oral pack into the oral cavity to facilitate surgery. Right, so the airway is shared, and the airway is inaccessible with the robotic instruments docked. The ETT is firmly secured in place. This should be ensured. And the endotracheal tube should neither be endobronchial nor too superficially placed. Bilaterally equal breath sounds do rule out endobronchial ETT, but they do not rule out an ETT cuff abutting the glottis. In such a situation, if the neck is hyperextended, as for TARS, the ETT cuff may slip partially or fully out of the glottis, resulting in an airway leak or compromise. So this can be circumvented by palpating the ETT cuff in the suprasternal notch. Then you'll find that the airway pressure might suddenly start increasing. The most common cause is a surgeon leaning upon your circuit. Then secretions and bronchospasm may be other causes. Now, the choice of airway equipment, it's tailor-made, for each patient, but most commonly, we utilize the CMAC D-blade video laryngoscope to place the contralateral flexometallic cuffed nasal endotracheal tube. But then there are choices you have to make. You have to choose between endotracheal intubation versus tracheostomy, depending on the airway, flexometallic cuffed endotracheal tube versus a laser tube, oral versus nasal tube, Macintosh versus a video laryngoscope, awake fiber optic or awake CMAC versus intubation after anesthetic induction, requirement of the surgeon versus safety and comfort of the patient. You should not compromise on the safety of the patient at any cost. If the surgeon asks you to extend and maximal extension at the atlanto-occipital joint is done, you risk C-spine injury. So you place a sandbag beneath the shoulders plus a folder towel beneath the head ring, and then during robotic neck dissection, the head is turned opposite to the surgical site. Don't overdo it because this might result in brachial plexus injury. The eye protection is important, and so are molded dental guards to protect your teeth. A flexometallic cuffed ETT of a smaller lumen is used. That's because you have to give maximum space to the surgeon and the robotic instruments. Now, this tube is also resistant to compression from the robotic arms, hence we use a flexometallic or armored tube. No nasogastric tube and no oral pack is placed intraoperatively to facilitate surgery, but remember, this compounds the risk of aspiration. 2 large bore IV cannulae have to be placed on the opposite side of the robotic chassis because later on you might not find place to put these cannulae. Fluid therapy should be restrictive because there's not much blood loss. Routine undocking is done after every surgery, but emergency undocking is to be done when you convert it to an open procedure in case of a cardiac arrest or in case of airway compromise. When there's an airway issue, anesthesiologist takes the lead role. You have to declare loudly for undocking, then there should be synchronized teamwork by the undocking team. Clear, concise communication. There should be an institutional protocol in place in such situations, and stimulated undocking drill should be done at regular intervals so that the entire OT team is prepared for such an adverse event. At the end of the procedure, we perform a Valsalva maneuver to ensure hemostasis. Nasogastric tube is then inserted. A final check by the surgeon is done for any bleeding or airway edema. Post-operative nausea, vomiting, and VTE prophylaxis is done. Duration and nature of airway manipulation is noted for potential risk of any airway edema, bleeding, aspiration, or airway obstruction. Reversal of anesthesia. Now, you have to, this depends on the type of surgery. If it's a primary surgery and the lesion is benign, then you can go in for an extubation. Then it also depends on your anatomical subsite. If extensive tongue-based surgery is there or a supraglottic resection is there, then you go in for post-operative ventilatory support. And if the patient is obese, has OSA or a difficult airway, then you awaken him, reverse him, but keep him intubated. Right. So post-op pain relief, you require less of this in case of TOS as compared to open surgery. The patient will feel the pain at 3 sites. Firstly, the surgical site. Secondly, at the tongue, because you have retracted it for prolonged periods of time. And the nasal septum will also pain because you take the sutures there to place the rise tube. The analgesia, you give multimodal analgesia as usual. Right. There are several complications associated with TORS. There may be skin or mucosal lacerations. There may be dental damage. Oral cervical communication is common. So mandibular and C-spine fractures are rare but may occur. Ocular injury may occur. 3 to 8% of the patients may develop post-op bleed on the 10th post-operative day. Aspiration-related pulmonary complications may occur. Then dehydration and dysphagia are other complications. Now for the future directions. There are newer technologies which are coming up. Artificial intelligence, 5G is coming up. Then newer research is required on TORS, and a step in this direction is a study of which I'm the principal investigator. The topic is assessment of stress response due to CMAC D-blade guided video laryngoscopic endotracheal intubation and docking of Da Vinci surgical robot using perfusion index in patients undergoing transoral robotic surgery. So results in a nutshell were that PI at laryngoscopy is a good indicator of PI at docking, enabling preemptive measures anticipating the docking-induced stress response. So you give a fentanyl bolus or you give lignocaine and you deepen the volatile anesthesia from MAC maintenance to MAC intubation at the time of docking of the surgical robot. So you should always remember that stress response to insertion of the FK retractor and robotic instruments is very similar to the stress response produced by laryngoscopy and endotracheal intubation. So here you can see that PI is more intense but shorter lived in case of endotracheal intubation as compared to docking. So PI displays a negative inverse relationship with the hemodynamic variables. Now this is Mantra, the first Indian surgical robot, and it's a new player in the market. It's challenging Da Vinci because the costs are declining because of it. The costs have been slashed to 1/3. The Da Vinci cost you around 10 crores, but Mantra would cost you just 3 crores. And at RGCI, we've just completed preliminary trials for India's first surgical robot, that is Mantra. So TORS is an evolution. Revolution is yet to happen. So stay tuned and be a part of it. Thank you for the patient listening. Any questions?
Thank you, Dr. Shagun, for that very crisp, colorful, and practical approach to transoral robotic surgery and anesthesia. We will take the questions after the third talk.
Right, sir.
Just to ensure that we stay on time. And hello.
Yes, sir.
And it gives me, it gives me great pleasure to introduce Dr. Sushma, one of my colleagues, a consultant anesthesiologist at Basavatarkam Indo-American Cancer Hospital. She takes keen interest in teaching her junior colleagues, and she's a budding speaker. Over to you, Sushma, for your topic on anesthesia for cancer survivors.
Good evening, everybody. Thank you, sir, for the introduction. It was a very enlightening talk by Shagun ma'am and Solanki sir. And I thank the organizers for giving me this opportunity. The topic for today, my topic for today is anesthesia and cancer survivors. And why are we looking into this? Because worldwide, we see there's a rise in cancers, about 18.1 million cancer cases being seen worldwide. And a similar picture in India, where 13.9 lakh cases are being registered every year. And whom do we call as cancer survivors? According to NCCN definition, an individual is considered as a cancer survivor from the time of diagnosis to the balance of life. In simple words, both a patient living with cancer and those free of cancer are cancer survivors. And about 50% of them face late treatment related effects. And with the advancement of treatment and better survival rates, more patients are able to live a cancer-free life. So we are bound as anesthesiologists to encounter any of these patients for non-cancer surgeries. So it is very important for us as an anesthesiologist to know the story, their cancer story, so that we can understand what treatment the patient has received, so that we can help them better. So that is the reason why we are talking about them today. I'll be dealing with a couple of case scenarios, perioperative concerns, radiation-induced changes, and opioids. What to look into, what to do, and how do we go about? Coming to the first case scenario, we have a 45-year-old female coming for lap hysterectomy who's treated case of right carcinoma breast who underwent MRM with adjuvant chemotherapy. She is otherwise a healthy female with no medical comorbidities, and her lab investigations were within normal limit. The concerns pertaining to this particular patient are cancer treatment related, which could be surgery related. When there is extensive axillary dissection, the patient can have lymphedema, which can challenge us with difficult venous access. Just apart from surgery, even patients receiving chemotherapy can have thrombophlebitis and can also challenge us with difficult venous access, and the dilemma where to tie the BP cuff, and other effects because of radiation. This patient had right lymphedema. Usually the contralateral arm is preferred for venipuncture and to tie the BP cuff. There's no strong evidence that the venipuncture can precipitate lymphedema. The incidence of arm lymphedema is much more in patients who are undergoing extensive axillary lymph node dissection. With the new surgeries where only sentinel node biopsies are preferred, their lymphedema incidence is less. And other risk factors like extensive surgery, obesity also are prone for lymphedema. These patients have some of these patients come with long-term venous access like a chemoport in situ. So as an anesthesiologist, we just need to know how to use it because it helps us in our venous access. For this, these chemoports can be used with a specialized non-coring needles and they have to be flushed before use. Coming to the chemotherapy-induced cardiotoxicity, these patients usually receive anthracyclines, which are known to cause arrhythmias in around 40% of patients and congestive heart failure on long run. And trastuzumab also causes decrease in the left ventricular ejection fraction. And immune checkpoint inhibitors can cause fulminant myocarditis, which can be rapidly progressing and has high mortality. And how do we evaluate these patients? We go into the history and examination of these patients' treatment records, and we need to look into their follow-up records of what treatment they have received, their cardiac status. And we need, in preoperative assessment itself, it is better to look into the venous axis. And few patients who receive tamoxifen are more prone for DVT. And investigations in specific to these patients, we look for a 12-lead ECG for any arrhythmias, 2D echo, where we look into the ejection fraction. There are variable studies for TROPI and NT-proBNP, but it says that series of serial measurements of TROPI can help us predict the ejection decrease in the ejection fraction. And lipid profiles are done in patients who specifically receive left-sided radiation and also any prior cardiac dysfunction, as they're more prone for dyslipidemia. And how do we optimize these patients? Patients with compromised cardiac function can also be prior on AC inhibitors, beta blockers, and diuretics. Electrolyte correction, and in case of any abnormality, has to be done. We avoid drugs causing prolonged QTC, avoid myocardial depressant drugs. So here we can prefer etomidate and TIVA over inhalational agents. Sorry. Coming to the second case scenario, here a 34-year-old male who came with acute appendicitis was planned for lap appendicectomy. He is a treated case of testicular tumor who underwent high inguinal orchidectomy, chemotherapy, followed by retroperitoneal lymph node dissection and salvage radiation. Otherwise, he had no other comorbidities, and the lab investigations were within normal limits. These patients usually for chemotherapy, they do receive bleomycin, which causes oxidative damage, and through inflammatory mediators can cause on a long term pulmonary fibrosis, which is usually seen at a cumulative doses of more than 450 milligram per meter square. And why are we worried about these? Bleomycin induced pulmonary toxicity has a mortality of 10 to 20%. And the radiation effects on lung, the early changes can present as acute pneumonitis, further progressing eventually to lung fibrosis. Radiotherapy, along with bleomycin or surgery, has a higher risk of pulmonary toxicity. So here we need to be careful in these patients while administering oxygen therapy and fluid administration. Even brief periods of high oxygen therapy. So we need to keep our FiO2 not more than 0.3. Even brief periods of high FiO2 can rapidly progress pulmonary fibrosis. And goal-directed fluid therapy, because these patients can be are prone for pulmonary edema. And how do we evaluate? We need to look into their treatment records, whether the patient has received chemotherapy and radiation. These patients can present with cough, exertional dyspnea, and on auscultation basal rails. Usually, bleomycin pulmonary fibrosis is a diagnosis of exclusion. So prior, we need to rule out any infective causes before coming to the doubt of bleomycin pulmonary toxicity. And investigations which help us are PFT, where we see a restrictive pattern of decreased FRC, decreased in total lung volume. And DLCO, it's a single sensitive test which can tell us the subclinical fibrosis, ongoing fibrosis. And HRCT is preferred over chest X-ray, and it is usually to establish anatomical diagnosis to know to what extent pulmonary fibrosis has happened. In these patients, as I mentioned, the FiO2 has to be not more than 0.3, and we need to accept a saturation of 88 to 92% and goal-directed fluid therapy. Coming to the third case scenario, we have a 59-year-old male presenting with recurrent cholecystitis, planned for lap cholecystectomy. He is a case of CA bladder who has received neoadjuvant chemotherapy, radical and underwent radical cystectomy with ileal conduit. He is a known diabetic under control, and his serum creatinine is 1.8 milligram per deciliter. And the concerns pertaining to this particular patient are renal dysfunction and metabolic abnormalities. In this particular patient, the renal dysfunction per se could be because of the chemotherapy drug the patient has received, diabetes, or the ileal conduit. And the metabolic abnormalities like acid-base disturbances, electrolytes, and bone demineralization should be looked into. These patients commonly receive cisplatin, which accumulates in the renal tubule and causes renal tissue damage. It is seen that about 14% of these patients have decrease in GFR up to 14 years even after completion of therapy, and finally resulting in acute renal failure. And the toxicities associated with doses more than 40 milligram per meter square per day. Patients receiving cisplatin can have electrolyte abnormalities like hypomagnesemia, hypocalcemia, hypokalemia, and hyponatremia. And they can present with paresthesias, tetany, convulsions, and cardiac arrhythmias. And they can also have hypertensive and serious vascular sequelae like MI and cerebrovascular accidents. The other chemotherapy drugs which affect the kidney, like cyclophosphamide, can present with hemorrhagic cystitis, vincristine, SIADH. Ifosfamide can cause proximal tubular abnormalities. And how do we evaluate these patients? Like any other previous patients, we need to look into the treatment records of chemotherapy and radiation. These patients can present with weakness and lethargy. Patients on long-term ileal conduit can present with weakness and lethargy, and other symptoms because of electrolyte imbalance like paresthesias, frequent fractures, and convulsions. So we need to be careful while positioning these patients because they're more prone for bone demineralization and frequent fractures. And investigations which help us are serum creatinine, arterial blood gas analysis, and electrolytes. And how do we optimize these patients? We need to maintain adequate hydration because to reduce the cisplatin toxicity, because that is accumulated in the renal tubules. Electrolyte correction, if any, needed, and avoid drugs prolonging QTC interval, avoid nephrotoxic drugs, and dose adjusted based on creatinine clearance. Our fourth patient, who was a 65-year-old female presenting with pain abdomen and suspecting intestinal obstruction, was planned for emergency exploratory laparotomy. Is a treated case of carcinoma esophagus who has received neoadjuvant chemotherapy followed by transhiatal esophagectomy. Is a known case of hypertension on treatment under control, and the lab investigations are within normal limits. The concerns pertaining to this patient are risk of aspiration, because these patients do not have any esophageal sphincter, so they're always prone for risk for aspiration when they come for surgery. And there is no established method where we can prevent risk of aspiration. There are studies who have done ultrasound guided compression of the conduit, but there is no proven evidence. And also the Celix maneuver will not work in these patients because the gastric pull-up tube is lateral to the trachea. And chemotherapy, these patients usually receive paclitaxel, which can induce peripheral neuropathy. And these patients with peripheral neuropathy can present to us with Cloven-Stock sensory neuropathy, autonomic neuropathy like paralytic ileus, and orthostatic hypotension. 30% of these patients will have chemotherapy-induced peripheral neuropathy for more than 1 year after the chemotherapy. So what do we do and what do we look into? We need to document presence of any peripheral neuropathy changes in these patients prior, because we might be administering regional anesthesia. Yes, we can, by administering low doses and trying to avoid adrenaline so that to decrease the neurotoxicity and and prefer ultrasound guidance so that we do not cause any direct injury to the nerve. Coming to other perioperative concerns in cancer survivors, that could be pertaining to chemotherapy effect on our brain, which is called chemo brain or brain fog. The chemotherapy agents cause oxidative stress on the brain by disrupting the blood-brain barrier and cytokine dysregulation, which can cause cognitive impairment. So that might affect the memory, attention, and the processing speed of the patient. About 1/3 of the patients experience these symptoms for months as long as 5 to 10 years. In breast cancer patients, it is seen up to 20 years. And why are we interested in this? Because these patients can present to us as post-op delirium, which could be challenging in the post-operative period. Coming to the hepatotoxicity of chemotherapy agents, these patients having hepatotoxicity can present with elevated enzymes, steatorrhea, coagulation abnormalities, and cirrhosis. So any patient coming who has received hepatotoxic chemotherapy agents, we always have to look into the liver enzymes and the coagulation abnormalities preoperatively. Apart from the chemotherapy drugs, patients receiving radiation for head and neck cancers and having surgery for head and neck with flaps, it is always a nightmare. They present with difficult airway. So we need all to have a plan. They can have anatomical obstructions because of huge flaps and have obstructive sleep apnea. Patients receiving radiation to the neck can present with hypothyroid and woody neck. Though the neck extension, everything looks normal on the outside, in the inside, we can see that there is laryngeal edema in these patients. So we always need to be prepared for difficult airway in patients who have received radiation to the neck in specific and who has undergone surgeries for head and neck cancers. Coming to radiation effects on heart, it can affect the coronaries, causing coronary artery disease, the valvular lesions. They can cause calcification, causes stenotic lesions. On the myocardium, it causes fibrosis and can present with restrictive cardiomyopathy and has conduction abnormalities, where these patients mostly are present with sinus tachycardia and high degree AV blocks. The radiation effects on CNS are because of the endothelial damage, and these patients are always at a risk of thrombus or hemorrhage. And the radiation effects on kidney. Kidney is a very sensitive organ, and these effects are seen when patients receiving more than 20 gauge of radiation, where acute radiation changes can present with edema, hypertension, fatigue, and anemia, finally resulting into chronic renal disease. Last but not least, we always have to remember that these are cancer patients. They could be in pain and they can be on opioids for a long term. So in patients who are receiving opioids for their pain, when preoperatively, we need to administer 50% of the daily dose to avoid opioid withdrawal. In case the patient skips the dose, we need to supplement it with equianalgesic IV doses. We always have to look into opioid tolerance, where there could be increase in the opioid requirement, and look for withdrawal signs too. Intraoperatively, for pain management, these patients have a requirement of 20% more of daily opioid usage. Intraoperatively, we need to look into withdrawal signs like hypotension, hypertension, tachycardia have to be seen. Coming to pain management in these patients, apart from opioids, we can manage the pain with regional anesthesia, regional blocks by adding adjuvants. It is seen that addition of adjuvants like dexamethasone, dexmedetomidine to the blocks can decrease the opioid requirement for up to 24 hours. And other non-opioid medications like NSAID, lignocaine infusions, clonidine and dexmedetomidine can be used. It is seen that with dexmedetomidine in particular, the opioid requirement is reduced for up to 72 hours. And ketamine, the requirement of opioid comes down by 40%. And to summarize, I would like all of us as anesthesiologists to remember to evaluate cancer as a new comorbidity and look into the treatment the patient received, whether the patient has received chemotherapy, radiation, and to look into the side effects of chemotherapy on different organs, evaluate accordingly, have a plan in place, and then proceed. And also, we need to plan for the pain management in these patients. Thank you.
Thank you, Dr. Sushma, for covering this elaborate topic so well. You've definitely covered the most important aspects, but I think as the attendees would understand that this was not a complete list. And what I feel is that every time you have a cancer survivor coming for anesthesia, it is important, like Dr. Sushma said, to go through the cancer story, even if it was years back and the patient says, oh, I'm completely cured of the cancer, I'm not undergoing any follow-up for my cancer. It is very, very important to consider cancer as a comorbidity, like Dr. Sushma said, and then go through the records. If the patient has received chemotherapy, radiation therapy, look into what drugs were used, how much amount of radiation was administered, and that is what is going to help you formulate a pre-anesthetic evaluation and anesthesia management plan. With this, and with Dr. Jayashree's permission, we will open this forum for Q&A session. You're muted, ma'am. Yeah.
Yes, Vibhavari, thank you so much. And I think we should take the questions that are there in the chat box.
Yeah, we seem to have quite a flurry of questions out there.
Yeah, I'm not surprised.
So the first question is for Dr. Sohan, and that is, what is the transfusion trigger for the cancer patient who is undergoing major surgery, maybe who's undergoing HIPEC? Would that be okay, Dr. Sohan?
Yeah. So in my talk, I also mentioned that we normally take a transfusion trigger of 8 is reasonably okay, but sometimes we can take 9 or 10 because if the patient is like having any some cardiac issues. But mostly in HIPEC patients, I personally keep transfusion trigger of 9. I want my BP HB to be more than 9. But yeah, sometimes we take 8 also, and sometimes we take 10 also. So 8 to 10, I can say roughly, but if I want to say 1 point, I will say 9.
Sure. And then just before we move away from you, Dr. Sohan, there's one more question on FFP. So before I ask you the question role of FFP, I just also wanted you to tell us, how do you guide the fluid therapy? Like, at what point would you move from crystalloids to colloids? If you use which colloid, and when does FFP come in?
Yeah, so this fluid therapy, I told that we use this like goal-directed fluid therapy. We use the SVV and PPV, and we also measure the delta SV, because sometimes your diaphragm is open and you will really, your SVV and PPV will really not be correct. So the delta SV is the correct way to measure to give the fluid therapy. And about the crystalloid and colloid, because sometimes these patients may have a lot of ascitic fluid and the jelly, so that will lead to a lot of protein loss from the body. So in that case, actually, we give maybe sometimes 2 or 3 albumin, but we give albumin as a colloid. So we make it around 4%. But what I saw in Japan, that they do not give albumin, but they use FFP as a colloid only. So they give a lot of FFP in the in the perioperative period. So they use FFP as a colloid, but we mostly use albumin as a colloid.
Yeah, I don't think it is a good idea, because there are a lot of recommendations against using FFP and blood products just as pure colloids, isn't it?
Yeah, also, but the Japanese use, American don't use. We use FFP just to correct our coagulopathy, but not as a colloid. But yeah, I've seen there in Japan, so I don't know what they think. Yeah.
At what INR do you use FFP? Is there a cutoff for you?
So we send this coagulation testing intraoperatively, and yeah, so my any INR, if I take around 1.5 or 1.6, then I definitely give FFP to correct it, because that ultimately, if you don't give any FFP by the end of the surgery, or if it's 12-hour or 14-hour surgery, your INR may go up to 2.2 or 2.4, and then you will need a FFP also, and the cryoprecipitate also, and so many. So if we correct simultaneously, it will be good, and that the field will also be better for the surgeons.
Sure.
Do you check the fibrinogen levels as well for correcting the?
We do not use a fibrinogen level normally, but yeah, so we just send the PT INR APTT in the from the OT, and we get, and sometimes we send the tag report from the OT. So if we think that our field is really bad, then we just send the tag if there's any issue. So based on that we can give. So the R time or the K time is so better than, yeah, based on that we can give our blood products.
Sure. I think we should move on to Dr. Shagun before we take up all your questions. So Dr. Shagun, there seems to be I think the most fearful complication an anesthetist can have is having to do an emergency undocking. So we have two of them who've asked about whether you've had to do emergency undocking ever, and what is your protocol? What do you think? How much time it takes?
Yeah, that's a good question. And actually, we've had to do it only once up till now. And this was a long time back, and after this, we have an undocking protocol in place. That time it took us, there was a bleeder from the surgeon's end. They could not control it using robotic surgery. So we had to undock in an emergency. It took us more than 2 minutes, So that day we realized that had it been a cardiac arrest, we might have lost the patient. So we have this drill in place now. We have an institutional protocol. We have dedicated OT technicians and OT staff, the scrub nurse and everyone who is, they belong to that TORS OT only. So that, and then they are trained regularly on a monthly basis. We put the robot in place, and then we blow a whistle and you dedock. There's a team leader. And of course, there are doctors involved, sisters involved, technicians involved, and everybody has a role to play. So with this, we could reduce our time to less than a minute. And I think 1 minute for dedocking or undocking is respectable time, and it can save plenty of lives and adverse events.
During TORS surgery, do you need to manage your blood pressures? Are there specific cutoffs that your surgeons would be interested in to actually improve their visibility?
So that's always an issue with the surgeons. They want hypotensive anesthesia initially, and in the end, when they are suturing, that time they want a Valsalva, that time they want the BP to be raised. So that's how it is. They want it around 100 most of the times, and towards the end, they want it to be, around 140, 150 with the Valsalva. We routinely do with the Valsalva. In fact, we have two techniques of doing Valsalva. One is the common technique in which we put it at 40 mm of mercury, and then you press the bag for say 20 seconds. Then there's another technique which we've devised. In that, what we do is we go to the pressure control mode in the workstation, and the machine provides it. And we find the latter is better because it's more consistent. Because even if you keep the dial at 40, the pressure which you're giving is only around 20 to 30. Which is not sufficient to dilate the vessels, and the bleeders which are lurking there don't come out. So this other technique in the pressure control mode is better. We've published a paper on that, and there's a study going on comparing the two techniques as well. Right?
Sure.
So
yeah, I think I'm going to ask Dr. Sushma to put her video on, because the next question is for Dr. Sushma. Can we see you, Dr. Sushma? No, you're still not visible.
My thing
Yeah,
is,
that's good.
That's
So, Dr. Sushma, there's a question for you. Are cancer survivors at a higher risk of infections in the perioperative period? And for how long after cancer treatment would you need to take this care?
yes, the cancer survivors are at a higher risk. It depends upon the recovery of their lymphocytes. Usually it's a short-term effect which they recover within 28 days. But in few breast cancer surgery patients, it is seen that it takes a longer and they come back to their pre-chemotherapy levels up to in 9 months time.
Sure. Thank you.
I think
we
two
Sure.
more questions for me, I think.
Yes. And I'm coming back to you. I didn't want you to keep talking all the time. I just wanted to give you a break. Okay. So your next question, Dr. Sohan, is that during the HIPEC phase, after say you've started vasopressors and you're already at the maximum dose of vasopressors and also fluid, you think you've given adequately, and the patient is still having hypotension, you send a blood gas or send an HB to the lab, which looks good. So what next would you want to do?
So in this condition, I don't think any vasopressor is like, if your BP is still low, I cannot say my vasopressor is maximum, right? There is no maximum dose of vasopressors I will consider. Also, no adequate fluid. If the patient is fluid responsive, I have to give fluid. So we have a good cardiac monitoring and the patient is fluid responsive, give fluid. Or you can change the fluid like from, if not crystalloid, can give colloid, but give fluid if your patient is fluid responsive. Sometime even after giving like all these fluids and vasopressors, you are giving one vasopressor, you can add another vasopressors, and because sometimes you may have some septic focus there, maybe in the body abdomen somewhere we have some septic focus, and that can lead to your persistent hypotension. So once only I started the vasopressin also into the operating room, because I was getting the same type of condition where I was giving the fluids, albumin, everything, and this noradrenaline was the maximum or supramaximal doses. But yeah, I'm not getting the BP. And then I started the vasopressins, and I really got a good result from that. So for me, you have to give like fluids and vasopressors, everything. So in that case, I mentioned about the one like HPI value on EDINE and the DDPDT, but it is not very available everywhere. So yeah, still we can, based on the, if a cardiac monitoring, we can give like, we again add vasopressors, or sometimes the inotropes also we can add as other than the vasopressor.
Sure. I just wanted to add our experience here. I'm sure Dr. Basanth would agree. There was a patient who received adriamycin for HIPEC, and not intraoperatively, but in the early post-op, there was reduced ejection fraction, which is a known complication of adriamycin. And in such situations, the use of inotropes, like you said, or maybe a little dose of inodilators could be useful, but you have to be using it very, very carefully, because you do not want the SVR to really drop down, and the blood pressure can also drop down. So it has to be guided with POCUS, echo, looking at the ejection fraction, and of course the hemodynamic monitoring, which shows the SVR.
And the fluid responsiveness, the fluid responsiveness sometimes continues into the post-operative period for 8-10 hours. Patient continues to be very fluid responsive. And there are times in the post-operative period where we need to give 4-5 liters of crystalloids, colloids, and blood. And so if you have a good cardiac output monitor, you know your volume status, you can continue to give the fluid as long as the patient is fluid responsive. And sometimes in the post-operative period, it can go up to 4 to 6 liters as well.
Definitely, and especially in the patient with the total pectomy and bilateral diaphragmatic splitting, they require a lot of fluid, and we have to give, the patient will be fluid responsive for at least 24 hours. Whatever you give, patient need more fluid. So it is, you have to give fluid. So there is no.
Yeah, sure. And then one more question for you, Dr. Sohan, and that is, what are the risks to the staff who are performing the HIPEC procedure if they are exposed to the chemotherapeutic agents?
Yeah. So the risk to the staff is high if we are performing the pipette. Like the risk is very high. So if they are performing the pipette, we only we either we should have a good scavenging system in the OT, or we should be standing outside the OT, seeing through the glass or to the monitor, because we do in that way, because most of the OT they do not have a scavenging system. So it's a pipette, but pipette is just for half an hour, so we can like just stand outside the OT. But during HIPEC, there is no really, aerosols are not really great, and they especially the surgeons who is there at the abdomen, which are like continuously staring into the abdomen, they always wear like a full mask type of mask with eye cover and all that. But for anesthesia people, we advocate to use N95 mask, and we mostly we do not allow a pregnant lady into the operating room during HIPEC phase, because they may have some effect. We don't know, there is no data on that, but they may have some theoretical problem. But mostly HIPEC is okay for all of us. If the patient, if your doctor is not, if it's not immunocompromised, then it's okay. Yeah.
Sure. I think there are a couple of questions, but the questions are on albumin and FFP, and I think you've already answered the albumin and the FFP part of it. Just one question to Dr. Shagun. Dr. Shagun, can I just, your screen? Yeah. Sure. Hi. No, I just wanted to know that, see, the indications for TORS are very, very limited. And I mean, robotic has many more applications, but the indications for TORS are really limited. So do you think it is just like a hype, or it is here to stay?
Well, it's here to stay. I'll tell you why. Because there are three reasons. See, cancer awareness is increasing. Cancer is being detected at early stages. So the candidates for TORS are increasing. So before the mandible gets involved or the maxilla gets involved, the patient can undergo TORS. Secondly, who doesn't want cosmesis? Who would want an ugly star on the face? And thirdly, benign lesions. You have an application for TORS. It's important. It has an important role for OSA patients, their obstructive sleep apnea, obesity pandemic. We'll get more and more of those. Then the cost of the robot is getting slashed. We have an Indian version now. Robotic surgery is going to cost 1/3 the rate. So why not have more and more of these? I think it's come here to stay. And I'm sure the market leaders also, they'll make sure that it stays. And of course, the patient and anesthetist will get benefited.
Sure. Yeah, I think we are done with the questions, and I think we had a great discussion. So it's time to start wrapping up. Before we do that, I'm going to ask all the seniors here if they have any more comments to add. Jayashree ma'am, if Radhakrishnan sir, if you have anything else to add to this.
Dr. Radhakrishnan, till he joins, I'd just like to make a few remarks. Of course, the vote of thanks will be later, but definitely this webinar has covered so much of onco anesthesia. And what I would like to just say is that, yes, we are all doing, not all, but many of us are doing robotic surgeries. However, many of us have not started transoral, and definitely it's a separate challenge altogether. As we see, robotic by itself is a challenge, and definitely transoral would be so. So that's one thing I would say, and learned a lot from Shagun. And so also the HIPEC surgeries, yes, the institutes which have been practicing it is definitely a place we must learn, and we must go to and learn, because it's not as simple. So your surgeon might just say, I need the HIPEC machine tomorrow for this surgery, but the anesthesiologist has to be very comfortable. It's not a easy ball game at all. And as far as the cancer survivors, yes, these patients are now definitely coming to us, all of us. And this is one area which we really have to study and be sure how we deal with them. So these were a few things, yes, because we are doing a lot of, we are not doing transoral, to tell the truth, Vibhavari, we are not doing transoral. We are doing a lot of prostates and other surgeries in robotic. And so also HIPEC surgeries, yes, but definitely the places, the institutions which are not doing, it means a lot. And cancer survivors will be coming everywhere for other surgeries, not necessarily to the tertiary care centers. So these are a few remarks that I would like to say, add on before we conclude. Anybody else would like to add on, whoever is there? I don't know if Dr. Kanchi is there. Possibly not. Sanish, anybody else would like to add? Okay, maybe they're all there. So that's from my end. And possibly for us, can we conclude before we, can we conclude now?
Yes, ma'am. Until now, there is no questions. I hope
Yeah,
that it was a really wonderful
there
session,
were
ma'am.
so many questions today. And what
Yeah.
I'd like to say is that today's webinar was nothing else but awesome. And
Exactly,
this is
ma'am.
what I would like to tell Dr. Basanth and Dr. Vibhavari, who were the moderators, and of course the speakers, Dr. Sohan, Dr. Shagun, and Dr. Sushma. It just showed how, how much they are into this program. And truly it was just a different level of a webinar. And the number of questions that came just showed the interest in the audience. So thanks a lot. And I have learned so much because, as I said, we are doing HIPEC and we are doing all these three areas we are covering, but I have learned so much, and I'm sure the consultants who are practicing in these hospitals where they're not doing so much of these surgeries would have learned a lot. So thank you so much, Dr. Basanth and Vibhavari, for moderating this, and Dr. Sohan, Shagun, and Sushma for the excellent lectures. And for Shagun, I will definitely want that she should share the protocol with me for the undocking. That's very important. So I'll request her, she can email me that.
Sure.
And thank you so much. And of course, it'll be a pleasure to see everyone in the next webinar. That would be next Wednesday, as was told, on the brain dead donor. And thank you so much. Thanks a lot. Thank you, Farhas. Thank you, Dr.
Welcome, ma'am.
Radhakrishnan, and Dr. Sanish, as usual. Thank you. And we'd love to see you all again. Thank you very much. Good night.
So
Thank
much,
you very
everyone,
much,
for
ma'am.
joining.
Bye,
And it
everyone.
was a
Thank you
really
so much.
wonderful session. It was a
Thank
really
you so
wonderful
much.
session.
I'd
We
like
are
to come
very
and visit you in Hyderabad sometime.
Yes, ma'am, definitely. Yes,
You're
please.
welcome, ma'am.
Yes.
Yeah.
Okay.
Next.
Bye-bye.
Yeah.
Thank you. Good night.
Yes, Dr. Radhakrishnan.
Sorry,
Yeah,
sorry.
we will request Hyderabad group to do the next conference, so we can all go to Basanth.
I
Sir,
think so. Yeah, they should take the initiative, Dr. Radhakrishnan.
we will consider this, sir, and we will
That's
get
a
back to
major
you.
hospital. That's a major cancer hospital.
I tell you.
Honestly, it's a major cancer
know.
hospital.
We will definitely consider this, sir, and get back to you.
We would love to hear from you all. Thank you so
Eh,
much.
I
Thank you,
really
thank you,
congratulate
everyone.
you, Basanth and Vibhavari, for excellent selection of the areas to be discussed today. And your team has done a wonderful job. Congratulations, keep up, and good night from my side.
Thank you, sir.
Thank you.
sir.
Thank
Thank
you.
you.
Good
Now
Thank you,
night.
thank you, Dr.
Thank
Shagun.
you. Good
Thank you,
night.
Krishna.
Good
Thank
night.
you.
Good night.
Good night, ma'am. Good night, sir.
Good night.